Aurelia, I'm clinical lead at CERCARE, and I'm presenting on behalf of Dr. Thormann from Magdeburg University Hospital in Germany. So this comparison of different CT perfusion software packages. I hope that I will honor his work and that he will be proud. But due to clinical duties, he's sadly unable to join us today. So that actually, the last question that was asked to Professor Berthesen was actually a good transition for this presentation, because at the moment many people would tell you that CTP is not needed anymore because all patients go to thrombectomy. So we talked about the latest trial like SELECT-2, but actually most sites still acquire perfusion. And perfusion was still required until recently for the extending window. And we can see that perfusion is going to increase accuracy and confidence in diagnosis. So, So even though we don't need it for selection for thrombectomy anymore, we still need it for diagnosis, and in particular for small occlusion like M3 and M4, which can be very difficult to identify on CTA. So it's going to improve confidence is diagnosis, and it's more and more important for hospital with limited resources, something that was also mentioned in a previous presentation, because maybe they don't have much experience in neuroradiology, and this is the paradox of CT perfusion. The less resources you have, the more high performance software you need. In Magdeburg, there's about 1,900 patients that are suspected with a stroke every year, and half of them have CT perfusion acquired. So we need a good software in order to detect the stroke, and you can see in here you have same patient that was processed with two different softwares, so CERCARE on the left and Singovia on the right, and you can really clearly see that there's big discrepancies in results. Completely different output. Singo, we have a core and a penumbra overlay that you can see. So red is the core and yellow is the hypo. We can clearly see like there's really a large core in comparison to the CERCARE results. And actually, in the end, the true core volume was found to be 6 milliliters. So basically, today, we don't know what to believe. Nobody knows what to trust. So the design of the study was made from 853 patients with suspected ischemic stroke from anterior circulation with CTP acquired, of course. Among those, 92 patients were taken into account because they had thrombectomy and a TK score of 2C and 3, so good recanalization. And we also got rid of the patient with artifact and severe bleeding that could alter the results in the volume segmentation. And we made the comparison between the two softwares, so Singo and CERCARE AI method, so the non-threshold results. So Singovia has 3 settings. The method B is the one used in clinical routine. So you can see that the method A and B, they are relying on the CBV, and the only difference is that they use or not smoothing. And the method C is going to be like similar to what we can find in another competitor, Rapid, with the threshold applied on the CBF. So for the purpose of the true infarct that was computed, just to tell that it was then manually segmented using ITK snap. And so first an example of a patient. We can see CERCARE on the left results. Yellow is the hypoperfused, purple is the core that was found. We can see the CBV map from Singo and the segmentation on the NCCT that was acquired as a follow-up for all the patients from this cohort. So we can observe with Singo that there's a larger core and a smaller penumbra, whereas in CERCARE you can see that there's a smaller core and a larger penumbra, and you can clearly see, I don't know if it's really, no, that's quite big on the screen, that you can see that CERCARE was the closest to the true infarct core. So among those cohorts, so I have 67 patients, we can observe that CERCARE was the closest in matter of estimating the true infarct core. SINGO in clinical routine, which was the B setting, is practically 3 times the size of the infarct, even more way beyond the true infarct core. Yes, and if we compare the true volumes to what Serker found, we can also clearly see that we have a median error of 1.3 milliliter, which is really low, and the overestimation was way lower than any other SINGO settings. So this is just the box plots to try to illustrate the table that we had just previously. So we can clearly observe on the box plot that CMN is closer by far to the true infarct core. The method B setting from SINGO appears to be the best setting, but still overestimates. If we take a little bit some time to take a look at Bland-Altman plots, so that is going to show the limits of agreements. It is quite small between Serker and the SINGO B setting, but Serker tends to underestimate the core a little bit. But we have to think about one thing, is that whenever a patient is coming to the hospital, getting his perfusion, and before going to the OR, you have a little bit of delay between 20 and 60 minutes. So having that much TK score that we took inside the cohort, we know that the lesion is going to probably enlarge a little bit, waiting for the thrombectomy. So actually, in the end, we tend to probably be really truer than the other measurement that we got with SINGO. So it's still closer to the estimation in comparison to what SINGO estimates, and we can clearly see on this plot that SINGO is going to overestimate, especially for lesion under 50 milliliter. So in comparison to all SINGO settings, CMN shows larger penumbra in comparison. We have a higher sensitivity to hypoperfused tissue that we can notice with the SINGO via, and an overestimation of the lesion. If we take a little bit attention to the sensitivity and specificity inside SINGO via versus Serker, we can see that Serker has higher sensitivity and specificity for low infarct volume, especially, where SINGO via has a low sensitivity for those same low infarct volumes. And if we take about the balance between sensitivity and specificity, it's really much better with Serker, when Siemens tends to detect stroke in every patient because of the high specificity. And so when getting those results, it was decided to go back into the database of the hospital and took a patient where we know that had no stroke at all on the follow-up. So there was, So first, there's a first conclusion about CTP has a high reliability to tell us when a patient doesn't have a stroke, and then that can also rule out even small stroke. So among all settings, only Serker and SINGO setting C provided 0 milliliter, and the possibility to find 0 milliliter segmentation. So as I was saying just a few seconds ago, we took other patients from the database and looked for patients with no stroke on the MR follow-up. So we know for sure that didn't have any stroke, and that had CTP acquired on the acute conditions. And so among those patients, that was around 60 patients in that cohort. They were processed retrospectively. We can observe that the median value for CMN is really 0 in comparison to high values in SINGO settings. And we know for sure that the true core is 0 for all these patients. A few patients were detected as positive with CMN. only like one patient was detected as 2.6 milliliter, which is really, really smaller in comparison to the other single settings. And if we take a look at the single via A setting, they actually detected huge volumes, such as 203 milliliter, which shows really significant amount of false positive estimation in stroke detection. So the same box plots for those 60 patients. Single basically detects infarct for every patient. There is not a single patient with no core. The method C looks to be most accurate, but still a lot of overestimation. And we can notice that single V results are far worse in patients with no stroke than in a cohort with a stroke, which is interesting when we talk about the evolution of the intended purpose of CT perfusion nowadays. So we can clearly see that CERCAR is the only software mirroring the MRI follow-up results in comparison to the other settings. So as a take-home message, in clear cases of large vessel occlusion and large infarcts, CTP is no longer fundamental because all patients go directly to thrombectomy, but still CTP is performed in clinical routine and in particular in centers with low resources. Stroke treatment might become centralized, so especially in Germany. Accurate stroke diagnosis will be increasingly important because there are still many clinics that needs to perform good diagnosis. CTP may speed out those diagnoses and increase confidence, in particular in smaller strokes. And the more centralized stroke diagnosis gets, the more smaller hospitals that don't have much experience in stroke diagnosis will transfer patients to larger hospitals. So we need the most accurate stroke diagnosis from the beginning. So CERCAR better estimates the true infarct core, and plus is better at detecting patients with no stroke. So very high negative predictive value, and may therefore save resources if the results are validated in a future bigger study. If you have any question, Dr. Thormann is available through message. You can come and contact me and have discussion. We also have workshop that would be organized in Magdeburg University Hospital if you want to meet Dr. Thormann. So there's obviously some limitation in that study. It's only one imaging protocol because a single center analysis. The infarct volumes are relatively small in that cohort, that few large infarct volumes, but it's what tend to be reality because we actually delivers what is treated nowadays in the OR. So I explain the only TICI 2C and 3 included. The next step will be to try to see how we perform on small ischemic and lacunar infarcts. So as you can see on the diffusion on the left side, actually at the moment there is no detection in CTP post-processing, especially in single via images that we can see. And some studies and research ideas could be really interesting in that matter. Thank you.
Thank you so much for presenting this so fluently.
That's right.
Do you know a little bit about the prediction or the AI that sits in this machinery, or is that?
Yes.
Yeah.
So what we apply in the AI method used with CERCAR is that we are going to compute first the hypoperfused volume, not relying on only one map, but on several. So we are going to use the coefficient of variance, the CBF, the TTP, the MTT, and the delay to use that. And a part of inside this volume, we are going to apply after the threshold of the CBF inferior to 30% in comparison to the full other contralateral hemisphere in order to really segment the core.